Dear students, dear colleagues, we continue the lecture series from the University of Pécs. Today's topic are depressive disorders. The epidemiology, let's see a few data on the epidemiology. Major depression, the lifetime prevalence is among 18 and 65 years is 15.1%. There are some differences in the terms of different continents and different countries, but this is a kind of data you have to know. Prevalence of affective and anxiety disorders in primary care is also about 15%. So these disorders are very important. These are very frequent disorders in everyday practice. So this means an importance for us. The symptomatology of depression. First, there is a mood symptomatology. You know that mood is an emotional state that permanently affects our consciousness. Hypothymia is the term which we use. Euthymia is the name of the normal mood. Hypothymia is the low mood. And loss of interest and anhedonia, which means the patient is not able to feel happiness, is also a very important symptom. Cognitive symptoms also can appear. Perception, attention, concentration, memory disorder of thinking, and negative cognitive patterns can appear. The depressed patient is like a person who looks himself, the world, and the future through a dark glass. This is called the Beck triad: negative view on the self, negative view on the environment, and negative view on the future. And these are what we call negative cognitive patterns. Vegetative symptoms can appear: insomnia typically, loss of appetite, lack of appetite, weight change, and sexual dysfunctions. And social and interpersonal problems also form a symptom cluster of depression. The depressed being in the world, to follow Heideggerian term, is a description, means that the description of depression or melancholy is a part of culture. Philosophers, artists, poets many times expressed how depression looks like from inside. And based on philosophical sources, we can say that depression is the opposite of a good quality of life. We can say a negative quality of life. The source of the depressed suffering is a negative self-view. So the patient is like who has a dark glass and everything looks darker than in reality it is. A major depressive disorder is the first in the DSM-5 I would like to mention. And what you see here are the diagnosis of major depression. 5 or more of the following symptoms have present during the same 2-week period, which is important, and this represents a change of the previous functioning. So these are the basic diagnostic criteria, and from the first 2 symptoms, one of them is needed. So the first is depressed mood, and the second is markedly diminished interest or pleasure, and activities most of the day are reduced, and nearly every day. So what you see, weight loss, what you see, insomnia, what you see, psychomotor agitation or retardation, fatigue, loss of energy, feeling of worthlessness, diminished ability to think or concentrate, and recurrent thoughts of death. So these are the symptoms which mean the major depressive symptomatology, and 5 or more from the following is needed during 2 weeks for the diagnosis, and from the first 2, at least 1. Okay. The second illness is persistent depressive disorder. Previously it was called dysthymia. In the DSM-5 this is called persistent depressive disorder. This disorder represents a consolidation of the DSM-4 defined chronic major depressive disorder and dysthymic disorder. So this is a recently introduced term. Depressed mood for most of the day, at least for 2 years. So it's a long course. Less serious symptoms, but much longer duration. At least 2 years is needed for the diagnosis. And in children, this is 1 year. What you see here is these most important symptoms, which are summarized in the DSM-5. poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, and feeling of hopelessness for the diagnosis. And during the 2-year period of the disturbance, the individual has never been without the symptoms more than two months. So it means chronic and long duration existing symptomatology. Okay, the third diagnosis, the third depressive disorder in the DSM-5, the premenstrual dysphoric disorder, a depression which is connected to the menstruation of the woman. In the major of the diagnostic criteria is that in the majority of menstrual cycles, at least 5 depressive symptoms must be present in the final week before the onset of the menses. And they start to improve within a few days after the onset of the menses and become minimal or absent in the week post-menses. So this is a mood disorder which is very much connected to the menstruation and the beginning phase of the menstruation. The fourth illness I would like to mention here is disruptive mood dysregulation disorder, which means a severe recurrent temper outburst manifested verbally or behaviorally. It's a child psychiatric problem. The outbursts are inconsistent with the developmental level, and the patient is many times irritable or angry most of the day, nearly every day, and it's observable by others, parents, teachers, or peers. For the diagnosis, the child should be under 12 years. The background of depressive disorder, there are genetic polymorphisms, which typically the genetics of the serotonergic system is responsible for depression, changes in the gene expression. It means a kind of predisposition of vulnerability, which leads to neurochemical imbalance and dysregulation of the monoamine systems. Typically, the serotonin and the noradrenaline system is involved in depression. Life events, traumas, and stress are important in the etiology of depression. And cognitive models, as we had seen, there is a cognitive disturbance in depression, the back triad, this negative worldview, these negative cognitive schemas are very much responsible for the development of depressive symptomatology. Learned helplessness is an animal model for depression. When, for example, a dog is put into a cage and he cannot burst out, and after a time the dog develops a clinical symptomatology which is very similar to human depression. And if the dog gets antidepressant, this kind of learned helplessness changes, and the so-called depressive symptoms of the dog disappear. Freud was very important and influential in the terms of establishing the psychodynamic background of depression. Aggression towards the self, which is a very important psychodynamic moment which is responsible for depression. So if there is an object loss, a serious person is lost, then not only the libido but the aggression is turned towards the self, and this aggression against the self is responsible for depression, and social factors play a role. Positive family history is important in the terms of genetic predisposition in depression. For example, in twin studies it was shown that the concordance rates in monozygotic twins is to 50 to 90%, while in dizygotics it's only 16 to 35%. This is a symptom, but which I show you, the very good fold, which means that in the medial part of the forehead you can see a kind of fold, a kind of sign which somehow represent the sad mood, the melancholic mood of the patient. As an integrative pathogenetic model, we can say that early loss and inheritance together, genetics and early separation problems, early traumas, together represent an affective temperament, and stressors during the adulthood leads to a limbic dysfunction, changes in the hippocampal volume or changes in the amygdala reactivation represent the limbic dysfunction, and these are neurobiological background of the depressive episode. Cognitive system is also involved, as I already mentioned. The depressed character can be grasped in the peculiarities of information processing. The depressed individual distorts the information in a negative direction. It is more likely to pick up signals that contain negative values and choose such behavior alternatives. So this is the back triad, when the patient is focusing and seeing the world, himself, and the future in a negative, from a negative perspective. Yes, this is what you see here, and early trauma, family disturbances, socializing problems can be the basis of this cognitive disturbance. The pathomechanism I have already mentioned, very important, the neurochemical, neurotransmitter background of depression, so genetics, vulnerability, early traumas, stressors leads to neurochemical dysfunction, dysregulation. Typically the serotonergic and the noradrenergic system is involved. Studies based on neuroimaging proved that there are structural and functional disturbances and abnormalities in the case of depressive disorder. Some neurophysiological differences are also detected from the 1970s. For example, the decreased REM latency on the EEG is typical in depression, and some neuroendocrine functions as overactivation of the HPA axis, higher cortisol levels, and different production rhythm, and DST positivity can be seen in depression as in Cushing's syndrome. So you give the patient dexamethasone and the normal feedback is not working, and what you see is that the normal negative feedback is not apparent. The outcome of major depressive episode, if there is a second depressive period, in the case of 50% of patients, 50% risk of second depressive episode following the first one, and 80 to 90% risk of a third depressive episode. And the more depressive episodes comes, what we see that the major depressive disorder become recurrent and chronic, and in the ICD diagnosis, what you see is the recurrent unipolar major depression, which somehow represent this kind of outcome of patients. There are gender differences in the symptomatology. Females typically show depressed mood, anhedonia, and sleep disorder, while in males, what you see is irritability, aggression, anxiety, alcohol, and drug use. So there is a difference between the symptomatology. The typical so-called male depression is what you see in the right side of this slide. Yes. Depression and suicide, we have already touched this topic in the first semester, that the risk of undiagnosed and untreated depression is very high. And untreated and undiagnosed depression can lead to suicide. Among women, suicide attempts are much more common worldwide. The female-male completed suicide ratio is 1 to 3. So more males commit suicide. And according to the literature, the prevalence of depression is estimated to be 50 to 80% in completed suicide, and 30 to 50% in suicide attempts. So what you see here, suicide, the background in many cases, in most of the cases in the case of completed suicide, is depression. There are some age-related characteristics of depression. For example, in infancy, what you see is apathy and sleep disturbance. Psychosomatic symptoms and enuresis can appear in the preschool, toddler ages. At school, educational performance and behavior disorder can be seen. Many times schoolboys with depression show aggressivity, and the background is depression, so it's not easy to diagnose. In adolescence, sadness, suicide thoughts can be seen, and the symptomatology is much more similar to the adulthood version. And in elderly people, there is often a latent form of depression. So the classical picture of depression in old age doesn't appear in many cases, and what you see is more the so-called depressive pseudo-dementia, that the patient complains on dementia symptoms, the patient complains on forgetfulness. When you ask a patient a test question, the answer, I don't know, I told you that I'm demented. So this is typical, the don't know answers, I don't know answers, and the patient complaining. The real demented patients do not complain on forgetfulness, and the environment detects the symptoms. In the case of depressive pseudo-dementia, the patient complains, and the patient speaks about the forgetfulness as a problem. Somatic complaints, sleep disorder can appear. The treatment of depression is complex, so combination of pharmacotherapy and psychotherapy. Antidepressants, specific aspects of drug choice is important. For example, if there is a serious psychomotor retardation, it's worse to choose a noradrenergic drug or a dual action drug, and augmentation strategies as folic acid and thyroxine can be used. A role of psychoeducation is important. You should teach the patient what depression is about, what is the pathomechanism, and how we can influence the symptoms with medication. Supportive problem-solving approach and goal-directed, goal-oriented psychotherapies as cognitive, dynamic, or family therapy can be introduced. And as an add-on medication, anxiolytics can be used if there is a serious anxiety, or hypnotics, typically the Z drugs, zolpidem and zolpidem, can be used. And with this, I would like to thank your attention, and I ask you to have a look in your book on the chapter of mood disorders.